Hi, everyone. Thank you so much for coming. I'm really excited to be talking about my work on biomarkers of the inflammatory response following brain injury. So when we think about brain injury, we have two categories that we group brain injury into. So we have traumatic brain injury, which is caused by an external force to the brain. So that's when we think of a gunshot wound, an assault, a fall. And then non-traumatic brain injury, which is caused by internal disease processes such as stroke, aneurysm, infections. Regardless of the cause, over 50 million individuals suffer from brain injury every year, and it's well established that there's high mortality and morbidity in these patients. Some of the chronic outcomes are disorders of consciousness, such as coma, language difficulty, problems with memory, difficulty walking, sleep disturbance, and personality disorders. So this is a source of productivity loss and disability worldwide. So the most common questions that neurocritical care physicians get when they talk to these patients' families is, where do we go from here? And what can we expect? What do we need to prepare for? And unfortunately, prognostication in brain injury is notoriously difficult due to the heterogeneity of the condition, and most brain injury patients die following the decision to withdraw life-saving care. So we do have some tools for prognostication. I'm not going to dive in depth to these, but to give an overview, Hunt and Hess is used in subarachnoid hemorrhage. The intracerebral hemorrhage score takes into account age. Glasgow Coma Scale. Glasgow Coma Scale is the number that patients are given when they come to the hospital, which indicates their severity. It ranges from 3 to 15, and it includes eye, verbal, and motor response. The impact score and crash TBI score are both scores used in traumatic brain injury, and they include similar things to the intracerebral hemorrhage score, but the crash TBI score also takes into account mechanism of injury. So unfortunately, none of these scales are perfect, and these tools lack accuracy, and more interestingly, they actually overpredict mortality and unfavorable outcomes, which, as you can imagine, really influences the decisions that these patients' families make regarding their care, the decision to withdraw care. So what we need and what we're focused on is an objective approach to improve prognostication. So circling back to the pathophysiology of brain injury, the pathophysiology is also broken into two parts, where we have the primary injury, which is the direct insult to the brain. It can be from the bursting of a blood vessel. And then patients in the days to weeks to months move into the secondary phase of brain injury. So when the brain is injured, there's edema, there's a mass increase in intracranial pressure that causes a decrease in cerebral perfusion pressure, so these patients get ischemia. There's a mass release of neurotransmitters, especially glutamate, which leads to excitotoxicity that causes cell death. And then there's a release of oxidative species, such as radical oxygen species, which also leads to cell death. And all of this leads to chronic responses that contributes to neurological deterioration in these patients. My work is largely focused on inflammation as a source of secondary injury. So within the first few hours following injury, there's a release of DAMPs, which are damage-associated molecular patterns, cytokines and chemokines that trigger the innate immune response. The neutrophils are the first to invade, where normally they cannot cross the blood-brain barrier. They invade and set off an inflammatory cascade. In the hours to days, monocytes infiltrate, and then eventually the adaptive immune system kicks in. And while acute inflammation responses are necessary to repair the body, persistent chronic responses can cause neuropathological changes. So a driver of inflammation that I'm interested in is the inflammasome complex. The inflammasome is induced by danger signals that come from damaged nerve cells, meninges, and blood vessels. It's composed of 3 subunits. So when DAMPs react with receptors, this NLRP3 sensor protein is upregulated. It can then bind the adapter protein ASC, and through autolytic cleavage, ASC cleaves pro-caspase 1 to caspase 1, which then goes on to cleave pro-IL-1 beta and IL-18 into their active forms. And not pictured here is also the cleavage of gasdermin D, which initiates pyroptotic cell death. So holes are poked in the cell membrane, which causes the cell to lyse and release its compartments, and that leads to a lot of inflammation and a persistent inflammatory response. We are interested in the inflammasome because it's been shown that inflammasome overactivation contributes to poor outcomes following TBI. This is the Glasgow Outcome Scale Extended, which is a score that I mention a lot throughout my talk, so I'll introduce it now. This is a score that's given to patients when they're discharged from the hospital to indicate their recovery, as well as at their follow-ups, so 3 months, 6 months, 1 year. It's on a scale from 1 to 8, 1 being the patient passed away, and 8 means good recovery. It might mean they're back at work, and then there's kind of everything in between. So this was a study done by Dr. Nadine Kerr, where they looked at serum of TBI samples, and they analyzed inflammasome proteins, particularly ASC. Samples in this study were collected 3 times a day for the first 5 days after arrival to the hospital. And what they found was that ASC was significantly elevated in patients in the first day and second day after arrival to the hospital. And the patients were dichotomized based on their Glasgow Outcome Scale Extended. So favorable patients were patients with a Glasgow Outcome Scale of 6 to 8, and unfavorable were 1 to 4. So my work is building upon this. We can measure sources of inflammation, including inflammasome activation in the body through various biomarkers. Biomarkers can come from various fluids as well as clinical assessments. They can be processed as a bulk or in various compartments, and then they have a lot of clinical utility, but mine is going to focus on the prediction of disease outcomes. So as I mentioned before, in my talk, I'm going to be looking at the whole, which will be plasma and CSF, and then break this down into smaller packets of information, including extracellular vesicles and immune cells. So the hypothesis of my studies is that elevated levels of inflammatory proteins correlate with poor prognosis following acute brain injury. And I'm going to look at this through 2 aims. So first, I'm going to be looking at inflammasome and vascular injury proteins associated with the inflammatory response in a non-traumatic brain injury model. And then I'm going to move into a traumatic brain injury model and look specifically at immune cells. So beginning first with non-traumatic brain injury, I look at aneurysmal subarachnoid hemorrhage. This is the most common form of non-traumatic brain injury, and an aneurysm is an abnormal bulge in a blood vessel, specifically when the blood vessel dilates to 1.5 times its normal size, and when it bursts, it causes bleeding in the subarachnoid space, which leads to a lot of complications. So despite neurointensive care in these patients, the outcomes are very poor, and the inflammatory response contributes to poor outcomes, specifically vascular and cellular compromise that leads to this response. So when the blood vessel bursts, damage-associated molecular patterns, especially ruptured blood cells, lead to an increase in pro-inflammatory cytokines. These cytokines lead to a decrease in tight junction protein, which hold together the blood-brain barrier. So then these products are released from the vasculature, and they lead to further inflammation. So in this study, we are looking at plasma and CSF. This was a collaboration with a hospital in Spain. So we have 15 patients with aneurysmal subarachnoid hemorrhage. It's 60% male, and the age range is, the mean is 62, standard deviation of 11, so it's a pretty even cohort. As a note, we have 15 controls of blood and CSF separately. The CSF is from patients with hydrocephalus because it's near impossible to get a healthy patient to donate their CSF. It's very hard. And then we measured inflammasome protein expression and vascular. These samples were collected 3 times a day, days 1 through 5 post-injury. So some of the biomarker technologies that we have on the first floor. The first technology that I use for the bulk of my inflammasome proteins is the Ella Protein Simple, which is an automated ELISA platform. You load the sample into the cartridge, and then the platform can analyze multiple analytes at a time. The reaction is done in these glass nanoreactors so that the samples can be run in parallel. There's no cross-reactivity, and they're also run in triplicate. The Simoa, or the single molecule array, is great because it can measure at the sub-picogram level. So the magnet binds to the protein, and there's an antibody coupled with it, and then it measures those on an individual level. So it's very, very sensitive. And then the MSD, or the electrochemiluminescence assay, is similar to an ELISA, but again, more sensitive and specific. So diving into the data, we found that inflammasome proteins are elevated in the CSF of patients with hemorrhage. So as we can see here, ASC is significantly elevated when compared to the hydrocephalus controls at days 2, 3, and 5. We also saw this in caspase-1, IL-18, and IL-1 beta, especially because the inflammasome proteins are elevated at day 5. It indicates there is an ongoing pathological process occurring at the site of injury, since CSF is a local picture. CSF acquisition is an invasive procedure. It requires the patient have an extraventricular drain or receive a lumbar puncture. So we then move to evaluate serum so that we can investigate inflammasome activation on a systemic level. Interestingly, in serum, we saw the opposite trend. Protein expression peaked at day 1 and then decreased as it moved towards day 5. And we saw this trend in the other proteins as well. IL-18 and IL-1 beta were not significant for all time points. IL-18 was not significant compared to controls. We hypothesize that this is due to the fact that these particular cytokines have multiple roles within the body in both biological function and pathological function. So it might be that these controls have other inflammatory processes going on. So the takeaways from this first set of data is that clearly there is a temporal profile difference between CSF and serum in these patients. ASC and caspase-1 are consistently elevated in both CSF and serum up to 5 days post-injury. So far, those are our more reliable markers. And the sustained inflammation in the CSF may be indicative of secondary brain injury. So we then wanted to evaluate biomarker performance. We used receiver operating characteristics and the area under the curve to do this. This is a picture of a receiver operating characteristic curve, and the area under the curve is the accuracy of the biomarker. So an area under the curve goes from 0 to 1, where 0.5, which is where this line is, indicates no discriminatory power. It's essentially a random chance that your disease state and your controls you can't distinguish it. So we classify a biomarker of 0.9 and above as excellent performance, meaning you have a 90% chance of being able to distinguish between the disease state and the control. Showing a representation, these are ROC curves for ASC, and these are well above 0.9. So these are reliable biomarkers. Given that inflammasome proteins peak early in the serum, and serum is easily accessible compared to CSF, we then wanted to look at the correlation of these biomarkers with clinical outcomes. So we did a correlation matrix, and we found that IL-18 and hospital days were positively and significantly correlated. So as the amount of IL-18 goes up in the blood, the patient's in the hospital longer. And then for ASC and caspase-1, they increased with mechanical ventilation days. And just as a note, the average days on mechanical ventilation for these patients was 17 days, and the average days in the hospital was 44. So inflammasome proteins in the serum do correlate with poor prognosis in this patient population. So while these inflammasome markers that I just showed are reliable and do seem to correlate with poor prognosis, they don't provide insight on vascular dysfunction. So I was interested in probing whether these inflammasome markers could be paired with another cohort of biomarkers that could indicate vascular disruption in these patients. So I looked at C-reactive protein and serum amyloid alpha, which are synthesized by the liver, and they go on to upregulate adhesion molecules. ICAM and VCAM1, or intracellular adhesion molecule and vascular cellular adhesion molecule, mediate adhesion and migration of immune cells. So going into the data on this, we saw that these acute phase proteins were significantly elevated, particularly at day 5 in the CSF. And for the adhesion molecules, they were elevated at both time points in the CSF, which is not surprising because this is a local picture of injury. In the serum, we saw that again, they were elevated at day 5, and then they were also elevated at day 5, the adhesion molecules. The adhesion molecules should not be free-floating, so this is indication that there's vascular disruption. We then dichotomized the patients by outcome, specifically their outcome at 3 months post-injury. So patients were again broken up according to this scale, where patients with unfavorable outcomes were categorized as a Glasgow Outcome Scale Extended at 3 months with 1 to 4, and then favorable outcomes were patients with a score of 5 to 8. And interestingly, what we found was that serum amyloid alpha was significantly elevated in patients with an unfavorable outcome. So our vascular injury protein takeaways was that increased circulating adhesion molecules may indicate ongoing inflammatory processes. The acute phase reactant proteins, CRP and SAA, provide insight into systemic inflammation, and serum amyloid alpha appears to be linked to poor prognosis following aneurysmal subarachnoid hemorrhage. So then we moved from the bulk to looking at smaller packets of information, starting with extracellular vesicles. So extracellular vesicles are of particular interest because they might be able to cross the blood-brain barrier. These vesicles come in 3 different sizes: exosomes, microvesicles, and apoptotic bodies. And why they're interesting is because in the normal state, they're involved in cell-to-cell communication, and they play a role in cell survival, proliferation, differentiation. In the injured state, they still take part in cell-to-cell communication, but what's been found is that if they're in the inflammatory environment, they can then carry this cargo to other parts of the body, which can have an effect on the inflammatory response as well as the clinical outcomes. So we isolated EVs from serum in these patients, and then we used a kit that has 37 surface epitopes to measure neuro-related proteins on the surface of these EVs, and we analyzed them using flow cytometry. And what we found was that EVs were significantly elevated in patients with aneurysmal subarachnoid hemorrhage. As you can see, there are more EVs here as well as on the graph. And then from there, we wanted to look at these EVs were neuron-derived. So we looked at neural cell adhesion molecule. Neural cell adhesion molecule normally is on the surface of neurons and glia, and if it's in circulation, it can indicate a leaky blood-brain barrier. So altogether, the conclusions of AIM-1 are that inflammasome and vascular injury proteins are significantly elevated in the serum and CSF of patients with hemorrhage. The EVs from this patient population carry proteins that indicate loss of blood-brain barrier integrity, and these proteins may be used as prognostic markers following injury. So moving into AIM-2, we looked at traumatic brain injury. We wanted to look at the contribution of immune cells as biomarkers of the inflammatory response. So for this, we looked specifically at neutrophils. We're interested in neutrophils because they're the first to invade after injury. They normally can't cross the blood-brain barrier, and when they do, in the case of injury, they set off an inflammatory cascade. So this is a collaboration with Aham Al-Kashroum, who's a neurocritical care physician. I work with his team. They consent the patients, and I go get the blood. I bring it back to Lewis Pope and process it here and evaluate the biomarkers. So of note, these are only comatose traumatic brain injury patients, and they actually includes acute brain injury as a whole. So we have patients with intracerebral hemorrhage, traumatic brain injury, and subarachnoid hemorrhage. Like I said, these patients must be comatose to be included in this study. Therefore, they're unable to consent, and we have to get proxy consent. They can't have COVID-19 or have cardiac arrest on arrival. I go and get the samples as soon as I can after consent, 72 hours after that initial collection, and then about a week after that. So we've been successful at getting patients for the study. Right now we have 40 patients. The age range the age mean is 51. We have 73% male, 57% white, and 54% non-Hispanic. And this is ongoing, so we're looking forward to getting more patients. The beauty of this study is that we have access to all of their clinical data, and the clinical team with Dr. Al-Khashroom gets a lot of other biomarker data, including EEG and EKG. And again, we look at ICU days, demographics, and we also look at their GASI. So when I bring these samples back to the lab, I do a magnetic bead sort to get neutrophils as well as CD45 cells. CD45 cells are important in this study because they represent all hematopoietic stem cells, so that we can look at the bulk of immune cells as well as looking solely at neutrophils, so we can see, are neutrophils driving inflammation in these patients, or are there other cell types that we need to be considering? And then from there, I use the similar technologies as in the previous study to look at inflammasome protein measurement. So beginning with CD45 cells, which are again the bulk of immune cells, we see that ASC, IL-18, and IL-1 beta are significantly elevated in CD45 cells. This is approximately 5 days after acute brain injury. That's the average of when our first sample is collected after injury. As a note, this is data on 27 patients and 7 controls. We have more patients that we are waiting to process, and we also have more controls. Moving into neutrophils, we see that ASC and IL-1 beta are significantly elevated in neutrophils after acute brain injury. So then we wanted to compare, looking just at the acute brain injury patients, looking at CD45 cells or neutrophils to see if neutrophils truly are the driver of inflammation in these patients. And we can see that in ASC, caspase-1, and IL-1 beta, these inflammasome proteins are significantly elevated in neutrophils when compared to CD45 cells as a whole. And even though IL-18 is not significant, it does look like they are quite elevated in neutrophils. And with more patients, we'll be able to look at this closer. So the goal of Dr. Al-Khashroom's lab is primarily to look at biomarkers of recovery of consciousness. So I similarly wanted to look at how neutrophils play a role in the recovery of consciousness. So I dichotomized patients into unconscious and conscious. Unconscious is a Glasgow Outcome Scale extended at discharge of 1 to 2, and then conscious is 3 and above. And we don't have any significance on this study yet, but it does look like the average is trending that the inflammasome proteins in neutrophils are higher in unconscious patients. A lot of our patients haven't recovered yet. These patients tend to stay in the hospital for quite a long time. The average stay is 33 days, but our longest patient has been there now for about 62 days. So as the patients recover and get discharged, we'll be able to add to this data set. So the conclusions from AIM-2 are that inflammasome proteins are elevated in immune cell subsets in patients with acute brain injury when compared to controls. ASC and IL-1 beta in particular are elevated in neutrophils when compared with CD45 cells. And our preliminary data shows that inflammasome proteins in neutrophils may be important in the recovery of consciousness. And this is something we're excited to continue to explore. So the overall conclusion so far are that biomarkers can come from different compartments, as we've seen, looking at plasma, CSF, EVs, and immune cells. Regardless of the type of injury model, ASC is consistently elevated in serum and CSF in both aneurysmal subarachnoid hemorrhage and TBI. And biomarkers, especially fluid biomarkers, cannot stand alone. They have to be paired with other clinical assessments to create a multimodal objective approach to prognostication. And we look forward to pairing them with markers such as EEG in the future. I went through that kind of process. I have a really big team that's helped me, and I would like to acknowledge my mentor, Dr. Dietrich, my mentor, Juan Pablo de Rivera Vaccari, and everyone in the lab that's helped me with these studies. My biomedical engineering mentor, Dr. Dumont, and their lab, which has listened to my talk many times. I have a great dissertation committee, the medical scientist training program that supports me, and of course also Dr. Al-Khashroom's lab, who consent the patients and play a massive role in making these studies happen. And any questions? Yeah. Mm-hmm. We actually didn't. Yeah. Yes. The neural markers meaning these ones? It probably, I mean, if it's inflammasome, it'd be like AIM2 neurons. I don't know. What region of the brain? I mean, if this is aneurysm, it generally happens in the middle cerebral artery, so more likely around the frontal lobe. Yeah, we actually don't know because with these patients, there's so many different things going on because they're also on sedation. So there's a lot changing that. The one thing about looking at an unconscious patient versus conscious patients is in a way you have less comorbidities because moving around, different things cause inflammasome markers, whereas in unconscious patient, there's less comorbidity when looking at the markers. But I'm not sure exactly the mechanism. Sorry? Yeah. And theoretically, their neuronal activity is decreased based on their EEG. Yeah, so in this, with the way we're processing, it's separate. So we take 2 milliliters of blood for CD45 and 2 milliliters of blood for neutrophils. So the neutrophils are not depleted from the CD45 population. Yeah, so when we run it on the ELA, when we run the CD45 cells, they're run in bulk, so we can't discriminate that the proteins are coming from the neutrophils at that point. If we did a different type of analysis, we might be able to, but the reason we do it separate is so that we're just looking at the neutrophils. The neutrophils are processed via a different magnet and a different kit, so it takes out just the neutrophils. So when we analyze it, it's looking very specifically at that. They arrive unconscious, and then they're on various levels of sedation. A lot of the patients are extubated. It's about 50-50 our split right now of patients that are discharged either, unfortunately, they pass away or they're discharged in a vegetative state to a very long-term care facility. About 50% so far in this study recover consciousness. And so when they do, it's because they've improved to the point where the physician can extubate them. Mm-hmm. Mm-hmm. Yes. So I could change my phrasing there. We don't consider it to be normal, but it's a control in compared to aneurysm where there's not a vascular disruption. Hydrocephalus is not as much of an inflammatory process. As we can see, the inflammasome markers are significantly elevated compared to the hydrocephalus patients for every single marker. There's no perfect, unless we can get healthy CSF, it's very hard to have a perfect CSF control. The ideal would absolutely be a healthy patient, but getting someone to line up for a lumbar puncture and an EVD, there's not an amount of money that a lot of people would do that for. But I agree with you. Yeah. Mm-hmm. Yes. Mm-hmm. Yeah, so that's a question we get asked a lot. So one thing is with recruitment, we only recruit patients primarily in the neuro ICU. So patients with very extensive polytrauma, they normally end up in the trauma ICU. Every now and then we recruit a patient from the trauma ICU. So our patients still have multiple trauma often. They might have a broken arm, but not as extensive as a polytrauma as a patient who ends up going to the TICU. And then further down the line, the purpose of this study is to combine inflammasome proteins, primarily in the plasma, with EEG, resting state EEG. And what my clinical mentor has found is that EEG is not as susceptible to comorbidities, and that is why it'll be combined with EEG. Mm-hmm. Oh, a ton.
To be excluded just to be sure that this hospital stay or the recovery from the trauma is related to the CNS injury?
So almost all of our patients get infections, especially from the ventilators. So it's not something we exclude. We do take it into account when we do the higher end computation and data analysis, but almost all of our patients have it. We don't necessarily need to look, we're not necessarily looking at if the inflammasome, in that particular study, if the inflammasome protein expression is coming directly from the CNS injury, but more looking at how all of it correlates to recovery of consciousness. But at the same time, by getting these early time points, especially the one right after they come to the hospital, most of them haven't had those infections yet because the ventilator-associated infections will come more in a week, 2 weeks. So by getting those early time points, we can also avoid some of that and be able to look more at the CNS injury. I mean, I think ultimately the goal of having a reliable biomarker, aside from prognosis, is it can identify novel therapeutic targets. So if down the line there is an intervention for an inflammasome protein, whether it's ASC, which I know Pablo's been working on in his lab, specifically IC100. Other things have been tested in aneurysms, cyclosporines, NSAIDs, simvastatin, with not that much luck. So eventually an anti-inflammatory therapy that could aid in better recovery. Yeah.
Yeah, so,
Hi.
so I'm Christine Taylor, here. We had conversations previously about Vaccari, and maybe it's that interestingly, all of the neurotrauma patients are treated with Vaccari as soon as they have hemostasis. So all of those patients will have this. Other anti-inflammatory medications definitely do not use like the non-steroidal anti-inflammatory effects. You wouldn't necessarily see that but I do think that it's consider steroids are not routinely used in this patient population unless there is some specific problem. So for example, they get airway exudation, they would get so on a patient. Yeah, so that's, I mean, I talked to Nadine about this quite a while ago, didn't follow it up, but I mean, I think it's really interesting to look at. If you go back into these patients that have collected, you can see the data that stuff with us. And we try to do it for 7 hours. So it'll be interesting to see if they got their first dose before we got your son.
Mm-hmm. Yeah, that was something I wanted. And so I've been working with Nadine. Let me unhide those slides. So one thing we really want to look at is more the mechanism behind EVs contributing to outcomes in these patients. So we isolated EVs using size exclusion chromatography columns, and we did an adoptive transfer into healthy mice. So we took EVs from patients with aneurysmal subarachnoid hemorrhage and then healthy patients, and we injected them into mice, and then we measured cerebral blood flow. We measured the blood flow at baseline and then 24 hours post-injection. So this is what the blood flow looks like. So the baseline blood flow, as you can tell, it looks normal. 24 hours post-injection with control EVs, so EVs from healthy patient, it looks pretty similar to baseline. And then really interesting, what we saw 24 hours after injection with aneurysm EVs is we saw these areas, these little black dots of hypoperfusion. And if you actually look on the blood flow machine, you can see that the baseline blood flow is about 1,400, but then these areas of hypoperfusion are about 400, 500. So something is decreasing the blood flow. So then looking at TTC, which can show areas of infarction, the brain with the control healthy patient EVs looks normal, but then with aneurysm EVs, we get this massive infarction. And these are ongoing studies. This is pretty preliminary data, but we're going to be working on these studies in the coming months. Yeah, from someone with an aneurysm, don't do it.
You know, it's really interesting in looking at that. It reminds me of the spreading depolarization microvascular response. So the EEG would be important. In order to look for spreading depolarization, you need a different EEG filter. filter, but there are some correlations with the surface EEG, and that would be worth looking at because they've definitely shown in TBI patients that these electrical impulses that propagate across the injured brain are absolutely related to microvascular vasoconstriction and ischemia, and the histology looks like that.
Be really interesting. Yeah. She's like, I'm done. Thank you.